Welcome back to Clinically Curious, fueling knowledge one concept at a time. Today we're tackling congestive heart failure, or CHF, a condition that can seem complicated, but once you understand the why behind it, everything starts to click. We'll walk through CHF using the nursing process, ADPIE, assessment, diagnosis, planning, implementation, and evaluation. No fluff, no overwhelm, just focused content for focused minds. Let's get curious about the heart. So, what's actually going wrong in CHF? At its core, heart failure is a pump problem. The heart can't push out enough blood to meet the body's metabolic needs. That leads to a chain reaction of compensatory mechanisms that try to fix the problem, but often make it worse over time. Number 1. Decreased cardiac output. When the ventricles weaken, from damage like an MI, chronic hypertension, or valve disease, they can't eject blood effectively. This lowers cardiac output, which means less oxygen and nutrients are delivered to tissues. Compensatory mechanisms kick in, and the body senses low perfusion and panics a bit. The sympathetic nervous system increases heart rate and contractility to try to boost output. The renin-angiotensin-aldosterone system, RAS, activates, holding on to sodium and water to increase blood volume. The myocardium hypertrophies, the muscle thickens to pump harder. Sounds good, right? Unfortunately, these compensations eventually backfire. The increased workload and fluid retention only strain the heart more, worsening the failure. Number 2. Fluid backup and congestion. Depending on which side of the heart is failing, you'll see different effects. In left-sided failure, blood backs up into the lungs, causing pulmonary congestion, dyspnea, orthopnea, crackles, and cough with frothy sputum. In right-sided failure, blood backs up systemically, causing peripheral edema, ascites, jugular vein distension, JVD, hepatomegaly. Number 3. Decreased perfusion. Tissues get less oxygen, leading to fatigue, confusion, especially in older adults, and poor organ function. Kidneys may even start to fail. Bottom line, CHF is a vicious cycle of weakened pumping, fluid retention, and oxygen deprivation. Now, let's assess our CHF patient, both subjectively and objectively. Remember, strong assessment drives strong interventions. Subjective data. What the patient tells you. I can't breathe when I lie down. Orthopnea. During your assessment, also note how the patient is breathing. Is it labored? Also, are they able to speak in full sentences? Patients may express, I wake up gasping for air. This is paroxysmal nocturnal dyspnea. Or they may say, I feel so tired, I can't even finish my meals. This could give clues into their fatigue due to decreased oxygen delivery. My shoes feel tight. Fluid retention and edema. Another sign of congestive heart failure is pulmonary congestion, in which the patient may express that, I've been coughing a lot, especially at night. Always listen closely. These symptoms often reveal the underlying patho. Objective data. What you observe or measure. Think quantifiable data. Look at their general appearance. Are they experiencing dyspnea, use of accessory muscles, or cyanosis? Another sign they may exhibit is restlessness or confusion from decreased cerebral perfusion. Watch out for distended neck veins, JVD, when sitting at 45 degrees. Is there edema pitting in ankles, feet, or calf? Monitor their vital signs. As the heart is trying to compensate for lack of blood flow and oxygenation, it may manifest itself as tachycardia, a heart rate greater than 100 beats per minute. Next, you may see hypotension, especially in advanced stages. On your cardiopulmonary exam, crackles or rales in lungs may be present. When listening to the heart, you may note an S3 gallop, that lub-dub-dub sound signaling fluid overload. Lastly, weight the patient daily. Sudden weight gain indicates fluid retention and is a good indicator of fluid balance. Diagnostics. Here's where nursing meets numbers. BNP that is elevated, 100 pg/mmL, indicates heart failure. The higher the number, the more fluid is being retained. Let's look at the ejection fraction. Ejection fraction shows the percentage of oxygenated blood the left ventricle pumps out with each contraction. Normal EF is 55-70%. CHF patients may drop below 40%. Another diagnostic test to review is a chest X-ray. Chest X-ray will show cardiomegaly and pulmonary vascular congestion. An echocardiogram confirms pumping efficiency and valve function. This is where you can find the patient's ejection fraction. Finally, you want to monitor for any electrolyte imbalances. Nursing tip: document daily weights, edema grading, and lung sounds. They show your patient's fluid trend better than almost any lab. Possible nursing diagnoses include decreased cardiac output related to impaired myocardial contractility, excess fluid volume related to compromised regulatory mechanisms, activity intolerance related to imbalance between oxygen supply and demand, impaired gas exchange related to pulmonary congestion. Your care goals might include maintain adequate oxygenation, SpO2 greater than 92%, reduce fluid retention, stable weight, decreased edema, improve activity tolerance, prevent complications like pulmonary edema or dysrhythmias. Each goal should be specific, measurable, attainable, realistic, with a time factor. SMART. Remember, all goals should be patient-centered. Here's where nursing action takes center stage. Diuretics, like furosemide or Lasix, remove excess fluid, decrease preload, and relieve pulmonary congestion. Monitor I&O and daily weights. Check potassium levels. Assess for signs of dehydration or orthostatic hypotension. ACE inhibitors like lisinopril or ARBs like losartan decrease afterload and prevent further cardiac remodeling. Monitor BP, renal function, and potassium. Watch for dry cough or angioedema. Beta blockers like metoprolol or carvedilol slow heart rate and improve ventricular filling. Check apical pulse before giving. Hold if less than 60 beats per minute. Monitor for bradycardia or hypotension. Cardiac glycosides like digoxin increase contractility and cardiac output. Check apical pulse for 1 minute before giving. Watch for digoxin toxicity, nausea, vomiting, visual changes. Monitor serum digoxin levels. Other meds include aldosterone antagonists to spare potassium and vasodilators to decrease afterload and workload. Nursing interventions include monitoring I&O, daily weights, positioning, oxygen administration, and dietary restrictions. High Fowlers for easier breathing. Legs elevated for edema unless contraindicated. Low sodium diet. Typically 2 gram per day restriction. Fluid restriction. Commonly 1.5 to 2 liters a day if fluid overloaded. Weigh daily and report more than 2 to 3 pounds weight gain overnight. Recognize early signs of worsening CHF. Take meds as prescribed. Never skip doses. Avoid non-steroidal anti-inflammatory drugs as they cause fluid retention. How do we know our interventions worked? We should see improved breath sounds and easier breathing, no new edema, stable or reduced weight, vital signs within normal range, BNP trending downward, the patient verbalizing understanding of their care plan. If not, reassess and adjust the plan of care accordingly. Nursing is dynamic, just like the heart itself. And that's CHF through the ADPIE lens. Complex physiology made clear and clinically relevant. If you found this breakdown helpful, give this video a thumbs up, subscribe, and stay curious, because great nurses never stop learning.